So let me introduce myself. My name is Chris Pallas. I'm cardiologist, MCG, Department of Medicine, section of cardiology. And I'd like to share with you a method of reading EKGs. This is something we go over a lot on the ward service when I'm attending. And indeed, I'm going to be showing you the packet, which you see here, is the packet that we use on the wards. Now, initially here, this is going to be an overview, okay? And it's going to introduce to you a method and a way of thinking about reading EKGs. Too often, when we talk about reading EKGs, this is the initial reaction, because people can think of one of two things. Either they think about nothing more than the basic physiology like sodium channels, ion flows, or they just think of lists of criteria. Neither of which help you when it's the middle of the night and you're tired, fatigued, and you need to make a decision, and you need to clinically recognize if something's life-threatening or not and know what's going on. So instead of this, actually, our goal is to make it like this. And what we're going to do is we're going to use just several concepts, okay? We're going to develop a checklist, all right? That'll put you in the ballpark 99.9% of the time, all right? So this first session is not about all the details. It's getting you to think a certain way and to give you an overview. This slide is just to remind everybody, and by the way, this packet is actually developed so people can take it at home. And you can use this as a guide on yourself. So we're just going to do it here via video. So this is a scheme, as I've pointed out. And the whole thing is to rapidly identify normal from abnormal, all right? As soon as we trigger, as we'll see, as we generate this list and this approach, as we hit an abnormality, we'll stop and we explode it and go through the differential, okay? So this is it, some very basic concepts. Not to insult anybody, but they actually are very, very simple. And I would actually suggest when you start thinking about EKGs and you're following me going through this, your intelligence and achievements are your worst enemy. Don't think too much, okay? You just got to think very simply, okay? The concept is, you know, what do you remember better, a list of 100 items or a good conversation? So it's a good conversation always. So what we're going to do here is we're going to talk. You'll see we're going to use deductive reasoning using these concepts to come up with diagnoses. Okay, these are the four things I put in front of me all the time. The three basic laws of electrocardiography. Of course, we're going to go over these in detail, but this is an overview slide. Leads as they relate to underlying cardiac structure. I can't tell you how important that is. The concept there is like you have to think of like the heart as the earth and the leads like satellites, geostationary satellites looking at surface of the heart. All right. Then we have to understand the paper that the EKG is generated on, because we're going to be making measurements. We're going to be making measurements with this. These are calipers, as you can see. Going to number 4, you can't do this without calipers, folks, okay? We're always measuring. I've been doing this now for almost 40 years. I don't trust my eyes. Okay, and this is important because we're going to be talking about, is something regular or irregular? Sometimes it's hard to tell with the naked eye. So this is it. 3 basic laws, leads and structure, what's the paper, the metrics of the paper, and then always use these. 3 basic laws of electrocardiography, very, very simple. This black T is a lead, okay? We are going to be talking about depolarization. When I say about depolarization, we're going to be talking about vectors. We're going to be talking about summing up vectors. So there's a sense of geometry and direction. A vector away from something, towards something. Starting somewhere, going towards something. Going towards leads. If depolarization, if we sum up all these vectors, and we'll go through that, how we do that. If they sum up, they're going towards a lead, you get a positive complex, okay? If it goes, here's my lead, if it goes away, you have a negative complex. And here we have a lead, and we're at 90 degrees, the vector is at 90 degrees to my lead, through this, drawing a line like this, and you have a biphasic complex. It's that simple. So here, by means of example, let's say we have a diagram of the heart. This is left atrium, the two atria, left and right, left ventricle, right ventricle, your valves, AV valves. Here's a sinus node. So let's talk about something starting in the sinus node. So we can see it's the most superior structure of the heart. So it has to go down to activate the rest of the heart, meaning it has to go towards those leads, the inferior leads. Think of these looking up, and that would generate a positive P wave. Okay? And there we actually just diagnosed sinus rhythm. All right? All right, leads and underlying structure. So I can't tell you how important this slide is. In fact, after I finish this slide, I'm going to pull it aside. Anybody that's been on the ward service with me will be laughing because continually on rounds, and we're going through EKGs, I'm always flipping over a piece of paper and I'm actually drawing this. Okay, and this is the way I think of these. This is a concept that it pays off in spades. I can't tell you how important this is. You have to understand. So I always think of the heart in this angle. Okay, here's the conduction system. Okay, there are the great vessels, sinus node, the AV node, then the bundle branches. Okay, so that's the underlying. That's the structure. I'd like to point out something, though, that's interesting. This becomes important. Is actually orientation of this, not only to leads, but orientation actually to itself. Notice that the atrium actually tilts under the AV node to a large degree here. So back to what we were talking about in this slide about something going towards a lead or away from a lead, we would see how it would become important that if something started down here, not in the SA node, it would be going up and away from inferior leads, and it would lead to a negative P wave. Okay, so that's how we're going to use this as an example. So then what's important to know is the leads in relation to my structure. So I think it'd be simply, let's talk about, these are the limb leads. These are the precordial leads. These planes are at 90 degrees to each other. This is a frontal plane, okay? And so we see here we have the heart, same angle, superimposed on, this is the axis graph that you see in all the EKG books. And it tells you where the limb leads are, 2, 3, and F, L and 1, AVR, in relation to the heart. So there's my inferior vena cava, so that makes that the inferior wall. So 2, 3, and F are looking at the inferior wall. Okay, they're looking up. Going back, that's them. That's the lead looking up, 2, 3, and F. L and 1, they look at the lateral surface of the ventricle. You can think of, it's easy to remember L lateral. So AVL in 1, and then AVR is over here. Now in this plane, you're going to hear me talk about this, and it actually becomes important when we talk about diagnosing VTAC and things like that. I think of this almost like a map of the United States. This would be the southeast, that would be the northwest, northeast, southwest. That's important because, as we will see, AVR is a very important lead, and we will see that in a little bit. We'll notice that having been said, if something starts in the sinus node and has to depolarize the whole heart, if we summed up all the billions of vectors, it would summarize into one vector going away from the sinus node towards the apex like that. Okay, so we're going to use that to our advantage. A vector, okay, understanding where these leads are. So knowing this, we can anticipate what normal would look like in these leads. That is, if using the basic law of electrocardiography, going away from a lead, it's a negative, towards it, it's positive, we can anticipate that AVR, the complexes, should all be negative because you're depolarizing the entire heart from the most superior structure, which is here, to the apex, and it summarizes it like that. On the other hand, you can imagine if, let's say, we had VTAC, and it started in the ventricle and went the other way, from here to here, AVR would be positive. So this is how we're going to use this concept, okay? Then we have the precordial leads. This is like a schematic of what you would imagine in a CT scan that you're used to looking at. We see anterior here, posterior, sternum, spine. This is the heart. Notice that the heart lines up in this plane. The septum lines up pretty much behind the sternum along the line of the spine. V1 and V2 are on either side of the sternum. Therefore, they're looking pretty directly. Notice the arrows, that's the counterpart is that flat part of this lead. The arrows are looking at that surface more directly. Notice the right ventricle, small and to the right. As we go through the precordial leads to V6, we go over more and more and more of the left ventricle. Okay, all right. So how are we going to use this, maybe looking ahead? Well, let's think of, let's say, pulmonary embolism. Okay, if somebody has a large submassive PE and they get immediate pulmonary hypertension and they dilate and blow out the right ventricle, okay, the right ventricle will no longer be small like this or positioned like this. If it under pressure, it's going to dilate. Well, what's it going to do? Is it going to push the sternum out of the way? No. Going to push the spine out of the way? No. Is it going to push the left ventricle out of the way? No. It's going to go one way, this way. Therefore, in an acute process like that, what would we assume in V1, using the basic laws of electrocardiography, V1 all of a sudden might experience these big, large forces as the ventricle, as there's more of the right ventricle under that lead and everything is going that way. So now let's talk about the most boring thing ever, the paper. And again, it's just part of the process, folks. I can't make everything look glamorous here, but this is a matter of the paper. You have to think about it. It's getting you where you need to go. It tells you time on a horizontal axis and vertical axis. It's amplitude, voltage. Okay, now this is, notice, I got the calipers over here, and now this is where it gets very important. We're going to be measuring from here on out. Okay, we have large boxes here outlined in black. We have small boxes. Okay, we're going to be counting. When we talk about voltage, we're going to use our calipers like this. Let's say the calipers start out like this. By the way, use your calipers overhand. Don't do this, okay? It's very hard. You can't see over your knuckles. So get used to doing it like this, and you can stabilize with your thumb and use your fingers to spread or contract them. All right. So what we're going to be doing, let's say voltage. We'll think about high voltage and like LVH. Well, we're going to be measuring amplitude, okay? Vertical axis. So we'll see how many boxes we got, small and large, okay? Meanwhile, time-wise, we're going to measure, let's say, a PR interval. And we want to make sure it's less than a large box. Well, we're going to set our calipers to that and then measure from the beginning of the P to the beginning of QRS. So this is how we're going to be using our calipers, okay? This is what this tells you. Normal values. Small box is 0.04 seconds or 40 milliseconds. You can use either terminology. Cardiologists and especially electrophysiologists like to use milliseconds. You can use 0.04 seconds or 40 milliseconds, whatever you want. Most beginning EKG books teach seconds. So a large box is 0.2 seconds or 200 milliseconds, all right? And in amplitude, 10 millimeters is 1 millivolt. 10 millimeters, 10 small boxes, okay? So we're gonna take this, and here we go, we're over here. So we're measuring, let's say, a PR interval from there to there, okay? And then we compare it to how many boxes we got. It's that simple. Or voltage, we're going to look like this. Okay. Then we're going to keep our calipers the same, pull it aside, and count how many small boxes we got, and add those up in terms of for voltage. So here's the daddy rabbit. This is where the rubber hits the road. This is what we're going to have in front of us at all times. Now, what's important here is you'll notice an order first of all. It's a scheme. It's a checklist. 9 items. Now, it's a checklist. Why is it a checklist? Well, think about anything. Think about pilots. You know, when you're in the cockpit, you have to make sure everything's good. You have to be efficient, and you have to be thorough. That's this purpose. So this is a checklist. Now, notice it has an order. What's important here is what I put underline and put in all bold and all caps. It's the same way every time. You can do any order you want, but do it the same way every time. That having been said, I highly recommend, and can't imagine doing it any other way, you can do any order you want after number 4. You need to do 1, 2, 3, and 4 in that order. All right? Period. They set the foundation for everything else. After that, you can do whatever. But, so you're complete, do it the same way. If you do it different ways, you're going to miss. You're going to forget. So you take all the stress off yourself if you do it the same way every time. We do this when we're training people to do interventions in the cath lab, when we teach them to do surgery in the OR, when you're flying an airplane, it's the same way every time. That's the only way. That's how you get used to what is normal. You can rapidly identify AB normal. Okay? Then, we'll go through these. Every time we go through here and we trigger an abnormality, we go down here and we hit a differential and we explode the differential. So that's where we're going. So this presentation, this talk that we're doing here is going to be an overview, but the rest of our sessions are going to be exploding this differential so you can see what we're talking about each step of the way and become totally complete. Okay? All right. So let's start here with number 1, looking at the rhythm strip. Okay. What is the rhythm strip? This is the rhythm strip. A standard EKG is set up. You have your limb leads here, 1, 2, 3, RLF. Precordial leads, V1, V2, V3, V4, V5, V6. They're always set up like that. Underneath it, this has 3, but typically there's just one rhythm strip. So they just pick one of these leads, either V1 or 2, typically it's 2. They'll pick just one, and they'll just run it continually so you get an idea about rhythm. Rhythm. You know, we're thinking that's the kind of stuff that kills people. Too fast, too slow. So that's why I go and look at the rhythm strip first to make myself see if they have a physiologic heart rate, and this is there's nothing acute, life-threatening going on in terms of rhythm. So that means when we go to the rhythm strip, we have to have a way to come up with rate, and this is how we come up with rate. Some people, I ask the students, you typically what do they use? Most people seem to use the large box method. Like one large box is like, you set your calipers, you look at the distance between the R's and see how many boxes there are. If the next R wave occurred right here, okay, the heart rate would be 300. If it's there, 150, then 75, etc. Okay, that means you got to memorize. Me, I'm just not that smart. I don't like to memorize, and I can remember the first 3. And what do you do if the rhythm is irregular? So what I do is I just count the number of QRSs on the rhythm strip, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, and multiply by 6. That makes it easy. That way I don't have to memorize anything. All right? So we start out with rate. Next, we're going to look at the rhythm strip, the same thing, and we're going to use adjectives. Now, this is going to sound stupid, but again, I have to tell you, don't be too smart. These general adjectives is how we're going to diagnose rhythms. I want to know, is it fast or slow, regular or irregular? Is there group beating or is there a pause? That's what we want. Okay, so what we're going to do is we're going to notice fast or not, slow or not. Is it regular? Regular, what do we do with regular? Regular is it's going to be either regular and wide or regular and narrow, a QRS. So what I do is I set my calipers to the R interval. I keep them the same, and I see, do they occur where they should occur? And they do. That makes it regular. versus irregular, where I come over here and set my calipers to that RR interval. And when I come over here, the next one should be there, but it's not. It occurs early. So I set my calipers to that. If that were going to be the new normal, then the next R wave should occur there, and it doesn't. It occurs there. And we see on and on, I'm continually changing my calipers versus up above, I don't have to change anything. So regular versus irregular. Then group beating, this is a very easy concept. Well, this looks irregular and chaotic. This is irregular, yes, but what gets your attention is not irregularity, but that everything occurs in groups. Therefore, group beating. 1, 2, 3, 4, pause. 1, 2, 3, 4, pause. 1, 2, 3, 4, pause. Okay? So that's important. And then pause. There is no groups here. There's just a irregular rhythm and then a long, long, long pause. Okay? Fast and slow. Regular and irregular. I'm also going to have to note the width of the QRS, so it would be wide or narrow. Is it irregular versus the regular, like we mentioned? Is there group beating? Very important. Or is there a pause? That's each combination of these, each time we hit one of these, let's say we're looking at an EKG and we go, well, it's irregular and fast and narrow. Well, that's one differential diagnosis, okay? Versus if it was regular and fast and narrow. That's how we're going. That's how we're going to generate. That's how we're going to learn to read rhythm. Okay. So now we're here, number 2. I want to make sure 2 and 3 are going to let me know, do I trust the EKG tracing I'm looking at? Okay. So this calibration, that is the EKG machine set on the proper gain. Is the paper speed the right paper speed? And the leads, are they placed in the right place? Now, let's look at calibration. How do we tell calibration? Calibration, we look for a calibration bar. Typically, it's on the left. It can be on the right. Either way, it doesn't matter. And it should be 2 large boxes. Here, I'm going to come up with 2 large boxes. See that? See how I use my calipers and how I measured? 2 large boxes tall, 1 large box wide. That tells me that the gain is proper. That tells me that these voltages, the height of these QRSs, is exactly how many small boxes they add up to be. That's important because when we talk about LVH, one sign of LVH is high voltage. So we have to know that we're counting correctly. That's what that tells you, okay? Now, calibration can be changed. Don't assume that it's always going to be okay. Typically it is. But it can be changed manually. For example, here in this EKG, notice that my standardization now is at least three large boxes tall. Note the arrows. And we did that manually so we could see where the red arrows are pointing, which is a delta wave. So we can change this manually if we want to amplify complexes to look at something that's small on the 12 lead. The other way this gets changed is inadvertently on typically on a non-cardiac ward where somebody hits the button wrong. All right. Now let's talk about lead placement. And we've already talked about this actually. Now we're going back to, notice how we're going back to, the next few slides are going to illustrate how we're going back to the basic laws of electrocardiography. We remember how the heart is oriented. All right? We know, therefore we know structure. The 2 atria, the 2 ventricles, this is the right side, this is the left side. This is atrial septum, ventricular septum. We know how our leads relate to the structure. Leads 2, 3, and F are the inferior limb leads, 2, 3, F. and they're looking up at that wall, okay? So on the body, these are placed inferior to the heart, looking up. Notice LN1, look at the left part of the heart, the left lateral. And AVR is here. Remember my analogy, the US. Southeast, northwest, northeast. If we summed up all if we summed up all the vectors, if our impulse, so we're going to want to know where the impulse that's depolarizing the heart starts and how does it get conducted through all the tissue. We discussed how the sinus node is the most superior structure. So if it depolarizes first the atrium, then the ventricles, it'll do it sequentially and create a vector going away from it towards the apex, the most distant, so more proximal to the most distant parts of the realm, all right? Therefore, if we sum that one into one humongous vector, it would be going from the sinus node to the apex of the left ventricle. That would be away from AVR. So using our principle of a vector going to a lead is positive and away from a lead is negative, what would we anticipate that AVR would look like in a normal tracing? Yes, it would be negative. The QP would be negative, the QRS would be negative, the T wave would be negative. All right? So that's screening for lead placement. Now, and that's normal. Now, what if we get an EKG and we're going to look real quick. So we're going to start using the method here. So let's say this is a rhythm strip. It's not, because it's not, these are three separate leads, but they're contiguous. So I'm going to set my calipers. So I have a regular rhythm. I'm going to screen for something bad, arrhythmia-wise. So I have a regular rhythm, and then I'm going to multiply by 6. The number of QRS is by 6, and I got a good rate. Go here to my standardization. It looks good. But I go to AVR, and I know that everything should be down, 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 right? Because you're going away from AVR. Instead, now AVR, everything is up, 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 meaning what? Meaning the leads could be misplaced, or I have dextrocardia. So you see, this is how the method works. Just doing a simple screen on this EKG, we've come up with an abnormality, and we've already generated a differential. Lead placement versus dextrocardia. Now, how would we determine, and this is typically on the wards where I ask the question, using what you know and what we've covered, what would you expect on the rest of the EKG if this was dextrocardia? Dextrocardia, by the way, is, instead of the left ventricle being in the left hemithorax, it's over here. Okay, so it's opposite where these leads are. That having been said, and using the tools that you know, what would we expect on the 12-lead EKG in the, say, dextrocardia? Okay.
Well, one of the places I would think you could look would be on the precordial leads, because like you said, in dextrocardia, the heart's on the completely opposite side, and so instead of, especially these lateral leads, showing a QRS that's positive as the heart depolarizes towards V5 and V6, the heart's over here, V5 and V6 would have a really negative QRS. Is that right?
That's right. Absolutely. So that's just using a very simple tool. So given what you just said, let's look at this EKG. Here we have everything is up. And now, how about the precordial leads? Do they look normal to you?
I think they look pretty normal.
Yes, because here we go again. Let's look at this side by side. By the time you get to V4, you're over a big part of the left ventricle. You will have a positive complex. I don't know if you can see that adequately on this small tracing, but notice as you go over more of the left ventricle, you get a bigger and bigger R wave. And here at V4, you have what looks like a normal R wave, meaning there's muscle under that lead, as opposed to this EKG, where everything is up, 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 and instead you have nothing but negative complexes, just like you were talking about. Okay? That's because everything is going away from those leads. Everything's over here. So the vector's like this, meaning away from, meaning negative component. So let's see where we are in our journey. We looked at the rhythm strip, looking for fast, slow, regular, irregular group beating pauses. We've looked at the EKG to make sure that it was calibrated correctly, so our voltages were good. We checked for lead placement. We saw a differential with an abnormal. We saw AVR was the canary in the coal mine, and it generated a differential if it was AB normal. Next, now we're going to start with 4. And again, 1, 2, 3, 4. You need to do these in this order. So now we're going to follow depolarization. That is, where the impulse that's generating each heartbeat starts. Okay? Our mission is to determine, does it start in the sinoatrial node? Does it start somewhere else in the atrium? Does it start in the AV node? Or does it even start in the ventricle? This is our mission. All right? Once we determine where it starts, we'll determine how it conducts. So if it starts up here, we'll want to make sure then it propagates distally normally through all these structures. All right, so let's see. What we want to do, first of all, normal is starting in the sinoatrial node, i.e. sinus rhythm. All right, so this is, our mission is to determine, does it start in the sinus node now. Typically when I ask people on wards, like, how can I tell that? Oftentimes I get the answer, you look for a P wave. No, a P wave only tells you that the atria was depolarized. Okay? Because look, if I start, if my depolarization cycle, if my cardiac cycle is going to start from an electrical impulse outside of the sinus node but in the atrium, it's still going to depolarize the atrium. I'm still going to have a P wave. So there is not just a P wave. It has to be morphology. The EKG can only tell you so many things. So it has to be identifying what a normal P wave would look like. So normal versus abnormal P wave. So here we go. Let's look at a 12-lead EKG. I'm going to reinforce what we've already done, not to bore you to death, but I'm going to look at what would be the rhythm strip. I set my calipers. I'm regular. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 times 6, 72. I got a physiologic rate. That's good. That'll sustain life. Not too fast, not too slow. It's regular, no pauses, group beating, etc. Then I move to calibration, set my calipers to 2 large boxes, and I verify. That's 2 large up, 1 large over. I verify. Using my calipers, don't trust your eyes, use your calipers, all right? So that looks good. Then I check for lead placement, looking at AVR, all right? That's AVR there, that AVL is there. This is AVR up here. P wave down, QRS down, T wave down, looks great. So how am I now? How are we gonna determine rhythm? Okay, we're gonna look at one place. We're gonna look at limb lead 2, all right? Limb lead 2, an inferior lead. Here we notice is pretty much lined up right where the vector would be. So we look at limb lead 2, and here we are. If the impulse starts at the most superior structure, okay, in the heart, okay, everything is under it. If you summed up the vector, it would be going away from this, depolarizing sequentially the atria, then through the ventricles, all the way to the most distal part of the realm, which is the apex, all right? Generating that. So the P wave should look like what? To limb lead 2. Limb lead 2 is almost directly lined up with this axis. So what would you anticipate a P wave would look like?
I think it would look positive in lead 2.
Sure, it would be a positive P wave. Very good. And here we see in limb lead 2, we see a positive P wave. Good. So we have sinus rhythm.
And the same manner, conceptually, I'd imagine in AVR, based on where it is, right here, that a P wave would always be negative there, like we've talked about before.
That's correct, because it would be doing exactly what you said. It would be going away from it.
Mm-hmm.
Okay. All right. Good. All right. So we've identified an upright P wave starting in the sinus node. What if the impulse starts here, down here? And we've discussed how, look, really this is an inferior, this part of the atrium is really inferior. Well, to depolarize the atrium, if I started down here, what would you anticipate the vector would look like if it started down here to depolarize the atria?
Well, lead 2 is inferior to lead, and you're moving away from it if you start at the bottom, and so I'd imagine it would be negative.
That's right, and that's what we look for. So let's look at the next EKG. Great. Okay, next EKG, here we go. All right. Now let's use the method here. I'm going to reinforce this. I keep doing this repetition as you're learning here. Repetition is key. Whether you're an athlete, a musician, a pilot, you have to practice, practice, practice. So that's why I keep saying the same thing. I quickly look at a rhythm strip. Notice this is truly a rhythm strip. It's regular. Notice I go all the way across, all the way to the end. There's regular. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Okay, 66, 70 is a physiologic rate. Here, my calibration bar is over here. They're too large. There it is. One across. There it is. Lead placement. Okay, now, what do we notice here in AVR? The QRS is pointing down.
Mm-hmm.
The T is pointing down, but the P is pointing up.
It is.
Meaning, just using principles that we know, if the P wave is up in AVR, then it is that P wave is depolarization of the atria, and it's going towards AVR, so it must be going not from up to down, but it must be going from down to up. That would make it a positive P wave in AVR, and a negative P wave in limb lead 2, and there we go, we see a negative P wave in limb lead 2. Okay? So now notice how a method alerted us to a problem with atrial depolarization early. Okay? And it allowed us to be complete, otherwise you could have missed this. Okay? So this is called, what would this be called? Sinus rhythm when you start here, okay, with an upright P wave. But now we have a negative P wave. That means it started elsewhere in the atrium. So this becomes an ectopic atrial rhythm. Ectopic meaning outside of the normal area. Okay? Now we're gonna have a checklist for the conduction system. 1, 2, 3. We're gonna check off. Did it start in the sinus node or not? How does it get through the AV node? And how does it get through these conduction tubes, the bundle branches, into the ventricle? 1, 2, 3. Check, check, check. We already did the sinus node, okay? Upright P wave in lead 2. Now we want to see about how does it get into the ventricle? How does it get through the AV node? So the conduction system, I'm not trying to confuse anybody here, but you got to think of the conduction system in terms of clocks and cables. Most people in the conduction system, they think of something it conducts, that is pipes, okay? And so that would be going through here, conducting through the AV node into the ventricle. But remember too, it's a two-edged sword. If there's catastrophic failure in any system up here, any part of the conduction system, the most distal parts have the ability to kick in at slower rates to support life, okay? These are called escape rhythms, all right? But right now we're talking about how it functions, typically how it gets through here. This is a topic for another talk, but I just want you to know that it's a two-edged sword, okay? But now we're talking about it in terms of conduction, which means we're talking about the AV node, okay? So we're talking about AV block. There are 3 types of AV block, okay? the AV node, okay, can either work efficiently, and how do we determine normalcy? We know that it takes a certain amount of time to normally go through the AV node, all right? And so there's a certain delay. That is measured by the PR interval, all right? PR, the beginning of the P to beginning of the QRS. That should be less than one large box. So notice how I'm using my calipers. I don't use my eyes. I measure and compare. So if it's longer, then there's an abnormality. Now, that would be first degree AV block if it meets one other condition, that every P is followed by a QRS. That is, conduction through the AV node is not normal in that it takes longer, but it's not so abnormal that there's a block. Every impulse does get conducted, and we can tell that by the relationship between the P and the R. After every P, there is an R wave, and each PR interval is identical. So the PR interval itself is long, but every P is followed by a QRS. So every sinus impulse gets conducted in, but inefficiently. Okay. Versus second degree AV block. Here are the two types of second degree AV block. Type 1 and type 2, Winkie-Bach 1, okay, Winkie-Bach or Mobitz 1 and Mobitz 2. All right. In Winkie-Bach, it's important to differentiate between the two, because in type 1 Winkie-Bach, there is gradual fatigue in this AV node. Gradual. So, and we say fatigue, we identify the fatigue by a PR interval that progressively gets longer. Notice how I'm having to reset my calipers. Okay. Until finally, there's a P wave and no QRS. Notice how this is irregular then. Okay? It's not regular like this. It's irregular. And this can occur in group beating. Okay? Group beating makes you think of AV block. So we go to the beginning of the sequence. When you see this, don't start here, start at the beginning. Set your calipers, measure your PR. Notice I have to reset my calipers. There. Then all of a sudden, look how the PR jumps and gets bigger, but it conducts. Have to set them again, and then we drop a beat. Now, notice that we have a dropped beat. We have a P and no QRS. We know that's a dropped beat. Dropped implies it just failed to conduct. How do we tell that was the case? Because the PP interval, which indicates the timing of the sinus node in reliability, the sinus node doesn't change. So the sinus node, we can tell this, we infer this because our calipers never change. The P occurs exactly when it should, okay, normal fashion, and then all of a sudden it doesn't conduct. We know it's type 1 because the PR got longer. Now let me give you some advice. I've seen a lot of good doctors get burned on this. If this sequence, by the way, between my fingers, that's called the Winkie-Bach sequence. Imagine if this was more than 4 beats. Imagine it was 20 beats. It often gets impossible to tell the difference in the PR interval as it goes into the pause. But one thing that you're always going to see, always, and one of the few things in medicine you can say is 100%. In type 1, in Mobitz 1, Winkie-Bach AV block, the PR after the drop beat, after the pause, is always shorter than the PR before. So that's a double check. So there are 2 ways you're going to double check for AV block, okay? You're going to look, number 1, for a dropped beat. That dropped beat is going to have to be exactly where it should be. That is, the PP interval will be the same. Then you're going to check 1 for PR interval. Does it get longer? And if it doesn't, if you can't see that it's getting longer, go to the PR after the pause, measure it, and compare it to the PR before the pause. And this one, after the pause, will always be shorter. Versus, let's go down here and look at type 2. Here in type 2, we see, let's see, now this is pausing much more frequently, isn't it? But we do see a dropped beat. First thing we do is make sure all my P intervals are the same. And they are. So the sinus node is doing exactly what it should be doing. Okay, these get into the ventricle. How do we know they get into the ventricle? Because I can measure their PR, and their PR is the same. Okay, but then you get a dropped beat. Okay, well, I told you it possibly could be type 1. So what do? We go to the PR after the pause and measure it. Okay, and notice if it was type 1, this PR interval would be shorter than this one, but instead they're identical. And this is type 2, second degree block. Important to note the difference is because type 2, notice how catastrophic this is and how many P waves there are compared to this. This often is a harbinger to complete heart block and need for immediate pacing or sudden cardiac death. Okay, this last one is just a means to illustrate third degree heart block. In third degree heart block, you can imagine that there's no relationship. Nothing gets through the AV node. So the atria do their thing, the ventricle does their thing. How do we determine that on the 12 lead? Well, we find our PP interval. And all the P's are occurring exactly where they should, okay? And there's no relationship between any of these PRs. Every PR interval looks different. And in fact, here, this P wave almost lands in the back of the QRS complex. And notice that that rate is slower than my ventricular rate, but the ventricular rate is just clocking along at its own pace, slow, okay? So there's no relationship between anything.
So that kind of goes back to your concept of escape rhythm, where since there's no conduction at all, it's a complete heart block.
Right.
That QRS is really the AV node's automaticity, or its automatic depolarization of the ventricles, and it's completely deaf to any kind of atrial.
That's right. And so this is exactly what we're looking at. That's very good. This is exactly now the concept. And how does this happen? Well, all of this tissue is capable, if you think of the basic physiology and you think of your ion fluxes and gates, well, all this conduction system is capable of doing that. It's just that down here it does it much slower. So because it gives everything up here a chance to do it, because the higher heart rates are better for you. But here we clearly see an escape mechanism. The ventricle is always slower, notice the rates, versus the superior structures. And we actually can tell where the escape is by looking at morphology and by looking at rate. And so we're going to do that later on. We'll look at that later on. That's not the purpose right here. Okay? And that leaves us lastly with looking at conduction after the AV node into the ventricle, and we'll be looking at the bundle branches. So now this leaves us where here at step 3, we've looked at where does the depolarization start, where does the cardiac cycle start electrically, how does it travel through the AV node, from the two atria, how does it travel, and how does it arrive into the ventricle through the AV node, and then how does it go through the conduction system into the ventricular muscle itself and cause systole or contraction. All right, and as we'll see schematically here, and we know anatomically, that we have a conduction, we have the cables, if you want to call them that, pipes, conduction system, that much more efficiently transmits an electrical impulse than does the myocardium itself. All right, so the concept was this is the conduction system, and we remember that it conducts, it comes through the bundle branches, it splits after it comes through the AV node into a right bundle here, a left bundle that goes into an anterior and then a posterior fascicle. All right, notice this is fairly superficial, and this is a deeper conduction system. So here we conceptualize it as a highway for efficient transmission and delivery of impulses. But remember, the same system can also act as a backup pacemaker unit if the higher centers fail to generate an impulse. The lower centers switch from being pipelines to being pacemakers. Okay, that's what that's about. So when this transmits efficiently through the conduction system, then into the muscle, you have a normal EKG, a normal tracing, a QRS. This is reflected by the QRS, all right? And we see here that the QRS normally looks nice and neat. And if we could measure this, we would see, and I'm sorry for the scale on this EKG, we could actually change it, but we can see that the normal QRS is less than 3 boxes, 0.12, all right? Notice in general how nice and neat the QRS, a normal QRS, looks. It's narrow, and that's reflected. Look how nice and spiked it is, okay? Nice and smooth, okay? It's not wide, does not have notching. It looks nice and discreet, okay? If there's a problem in the bundles, there's a block, let's say in the right bundle, or a block in the left bundle. These are called the right bundle branch blocks, left bundle branch blocks, etc. You end up with a wide-looking EKG, all right? For example, the EKG then starts to look like this, where we can see, notice this is right bundle branch block. We can see that the QRS is distinctly wider than 3 small boxes. Okay, here it's almost a large box wide, all right? And that's reflected throughout the whole EKG. All right, so that's a quick screen. So you have a right bundle branch and left bundle branch block.
So I guess one way that you could think about it is with the normal EKG with proper conduction through that His-Purkinje system, it's kind of like traveling through an interstate very quickly. So we know time is the x-axis, so that time is very short, and so it creates a narrow QRS. But then in a bundle branch block, because the myocardium depolarizes across so much slower than through the highway, that's kind of like taking back roads to get to your destination, and that's why it's so much wider.
That's right, and we're going to get the detailed, a more detailed explanation of telling right from left bundle. But remember, right now we're just going through the method. So we're just showing a normal QRS versus being able to recognize an abnormal QRS. What you were mentioning is absolutely the truth, and the concept in general is just like this. So this is right bundle branch block. Okay, both of the bundle branch blocks have a wide QRS. Here we have the right bundle gets blocked. So what happens is the impulse, instead of coming down here and simultaneously going through both branches to get the ventricles, which gives you a nice, narrow, neat-looking QRS, a block, let's say in the right system here, means the impulse can't get past it. The impulse goes normally through the left system, and the only way that the right side, distal to where that block is, can get activated is from the left. So this impulse goes through here and then goes there, all right? Conversely, the same thing would happen the opposite way. If there was a block on the left side, the impulse would come down, stop, and all the left structures would get activated from this impulse coming down this way and then traveling into the ventricle. And so we'll go into the detail. This is not the place and the time to go through diagnostic criteria. And this is just a schematic, which we will go into detail later on, showing the difference in morphology between a right bundle branch block and a left bundle branch block. Notice just in general that in the right bundle branch block, the typical findings are found in the right leads, okay? That notice V1 is a rightward lead. Remember our schematic here. Here is V1, and it's looking right at the right ventricle and the right part of the left ventricle, okay? So it's a rightward lead. That's on the right side of the sternal border, okay? And then the left bundle system, here we see the schematic illustrating what I just said. There's a block in the left. The left has to, therefore it gets activated coming from the right, because you had a block here, and it goes left to right, left to right. And here the indicative leads are in the lateral. You see the lateral involvement for the typical changes in the lateral leads. Again, we'll go into that in detail when we get to it, but that's just illustrating the point.